Well, good afternoon, everyone, and welcome to OCD Action's clinical panel session. Before we start, we have Dr. Drummond, who would just like to offer her apologies.
Hello, everybody, and I'm here to just say I'm really sorry. I'm not going to do the Q&A session because I had surgery 6-7 days ago, and I'm not feeling very well. So I need to go home and sleep, but you've got Dr. Elenia Pampaloni, who is standing in for me. She's an expert in OCD in her own right and has worked in a variety of different countries in OCD, and I'm sure will do a great job. So I'm really really sorry for not for bailing out, but I'm going to.
Thank you, Lynn, and wish you well.
Bye.
So as I said, good afternoon and welcome. The clinical panel session today is called Effective Treatment Q&A. My name is Maria Bavetta and I'm co-founder of Maternal OCD. I've experienced and recovered from perinatal OCD. So panel, what I'd like you to do is to please introduce yourselves. Now, I know we all know and love you, but actually we must remember we have a global audience today because we're having some live streaming being done. So as well as saying your name, I'd love you to cover a couple of hats that you wear, and also if you have a particular OCD interest. Amita.
Hi everybody, I'm Dr. Amita Jassi. I'm a consultant clinical psychologist in the OCD, BDD and related disorder service for young people. So the hat I wear is very much expertise in OCD in young people. I also have expertise in OCD and ASD and also early intervention and prevention, so lots of work in schools and getting people access to services sooner.
Hello, I'm Bruce Clark. I'm a consultant child and adolescent psychiatrist. I work in the same team as Amita at the Maudsley Hospital, so it's the National Specialist Children and Young People Service. I'm also the clinical director for all of the children's services there. So I'm obviously interested in children and young people and their treatment for OCD, and like Amita, I have a particular interest in autism spectrum disorder and its interrelationships with OCD.
Hi, my name is Dr. Elenia Pampaloni. I'm a consultant psychiatrist. I've always had a special interest in OCD since I was working in Italy in 2004, and then I moved to England where I work with Professor Feinberg. Then I became a general adult psychiatrist, and now I work with Dr. Drummond at Springfield Hospital at the Trustwide and National Service for OCD and BDD. And I'm training in CBT as well at the moment.
Thank you. David.
My name's David Field. I'm a consultant psychiatrist and cognitive behavioural psychotherapist, and I'm based at the South London Maudsley Hospital Trust, and we run a national specialist service for people with treatment-refractory OCD and BDD at both the Bethlehem and the Priory and at the Maudsley. And we do research at the Institute of Psychiatry.
Hello, my name is Paul Shalkovskis. I'm Director of the Oxford Centre for Psychological Health and a few other things. We 2 weeks ago opened a new NHS clinic, national specialist for all kinds of things, but mainly anxiety disorders, children and adults, big components, OCD and hoarding. And I've been working in OCD since 1977, which is quite frightening for me, even if it's not for you.
Thank you, panel. So audience, if you are tweeting today, I know I've been following really well this morning. Please use the hashtag OCDAConf19 because it means people can really be here even if they're not physically in the room. So if we go to the questions, these have all been pre-submitted and we had an enormous amount of questions come in. So a big thank you for all the submissions. We're going to try to get through as many as possible, and I know that some of them you may actually have heard this morning, but I think it's really important because of that global audience that we still answer the questions that have been submitted. Most of the questions are about treatment, and this is a treatment Q&A, so I'll kick off with the first one. And I'll go to you, David, for the first one, please. If people suffering from OCD are rational and naturally intelligent, why can they not outsmart the bully?
The reason why you can't outsmart the OCD bully is because it's driven by your threat system. And your threat system in your old brain is trying to keep you safe. And so generally, safety wins first. You know, it's better to be safe than sorry. And it's better to miss lunch than be lunch. So that threat system is there to keep you safe, and therefore that will be prioritised. So, you know, you can be rational and so on when it's not activated, but there's always that difficulty in the brain.
Thank you. Any other panel member want to comment about why we can't outsmart the bully?
I'm going to disagree. You can outsmart OCD. You can outsmart, that's what CBT is. CBT is about outsmarting OCD and realising what it is you're fighting. Yeah, no, it's difficult. I agree. It's, wow. You mean it's difficult to treat OCD? I didn't know that. Oh my God, I better shut up now. Okay, thanks.
Thank you. Bruce, if I can come to you next. It is often mentioned, and it says here in inverted commas, that you learn to distance yourself from the thoughts. How do you perform this technique? Is it actually possible to do this?
I think it'd be better to pass that one to Amita, actually, as someone who
Bruce.
treats children and young people with CBT for OCD.
Thanks, Bruce. So I guess we're coming from a young person service where primarily, and the evidence base shows this, and what we do in the clinic is do exposure with response prevention. And I guess that kind of serves two functions in kind of the work that we do. One is that you learn to tolerate distress and it habituates, but also you get to find out something new about those thoughts, that they don't come true, and that, as David said, this kind of threat system is kicking off, and it doesn't necessarily mean that those thoughts are true. So I think in our experience, the way we would get that distance from thoughts is through doing exposure work and I guess with adults, I guess it's more behavioural experiments to get that distance from the thoughts. I don't know if anybody, I'm sort of talking from a young person service perspective, so I don't know if
You look like you had your hand up, Helena. Did you want to?
No.
No, okay.
So just to probe a little bit further,
Okay.
where the second question of this is it actually possible to do this? And I think it's trying to understand when you're feeling that anxiety, when you're carrying out the anti-OCD behaviour, how do people get over that feeling of anxiety?
I think sort of in our clinical experience, it is about that knowing that anxiety will habituate and being able to tolerate that. And this is on the basis of, part of our treatment is doing psychoeducation, really understanding how OCD works and learning about how anxiety works and that threat system. So having a really good foundation and doing things step by step using a hierarchy can build up that confidence that then can help people think about those thoughts differently.
Thank you. The next question, I know you covered some of this in your last session, Paul, but I think it would be helpful to dwell on it a bit longer. We've had some questions from a number of people outlining that their fear is unique, whether it's radiation, whether it's afterlife. You mentioned asbestos earlier. How can the ERP, exposure and response prevention technique, be used in these cases?
Everybody's problem, by definition, is unique, and every person is unique. What I was saying was that also from the perspective of the person experiencing these obsessions, they are real. But it's also very difficult for somebody with obsession A to then understand that obsession B, is also real because it doesn't seem real to them. It's a little, there's all kinds of examples of that. I actually think that, I've already talked a little bit about how I think treatment works, and I don't think it works purely through exposure and response prevention. To rely purely on exposure and response prevention is essentially saying stop it. Yeah, and stop it does not work. It's actually placed in context where people come to a different way of thinking about their problem. And that could be a simple way of thinking about it along the lines of, say, Jeff Schwartz's brain lock, or something a bit more complicated along the lines that perhaps David Veal and Fiona Chalcombe, Victoria Bream and myself would use. And I think it's actually not about the exposure and response prevention. Sometimes you don't need to do it. I think mostly you do, because in the end, if you're avoiding loads of stuff, you need to go for it. But as far as I'm concerned, it's in that context, and that's where the devil is definitely in that particular detail.
So because we had so many questions about people feeling their fear is unique, is there anyone else on the panel that just wanted to add to anything that Paul has said? Your head moved as if you thought you were going to.
I think I would perhaps just say a word, because people come back to this and they worry that they are perhaps unique and therefore treatment won't be accessible to them. And I just think in experienced therapists' hands, I really wouldn't want to see people thinking that they shouldn't seek treatment because it's so frightening, they've never heard or read or anything like that. I would actively encourage people to come forward for treatment. Whilst every individual is unique, the principles can be wrapped around that individual scenario. So, treatment will work for every one of you. If you work hard, it will make a difference.
Thank you. And that's an interesting lead to the next question, and I suspect there'll be a split in the panel. There are some times when good quality treatment has been received and has not been effective. What are the alternatives to CBT and or medication? Elena, if I could come to you for that. Or we can speak louder. Would that be even better? Yeah. Right, so there are some times when good quality treatment has been received and has not been effective. What are the alternatives to CBT and or medication?
So, the alternatives I'm aware of, there is some evidence for repetitive transcranial magnetic stimulation, which has recently been approved by the Food and Drug Administration in the US. So that is a technique that uses a magnetic field that is applied onto the scalp, and it kind of generates a magnetic stimuli that, because of the induction system in our brain, generates electric current in a quite well-defined spot. So it's usually you can use it on very small areas of the brain, and you need to have, I don't know much about the details, but a number of consecutive sessions, and it's like sessions usually last half an hour, and there is some evidence for that. It's not approved in the UK. And the areas of the brain where it's been tried on is the prefrontal cortex and the supplementary motor area. It's a technique that is, in England, is used in treatment-resistant depression and is actually approved by NICE in that respect. It's always been difficult to use it in OCD because of the areas that you're going to target are deeper, so it's not as easy to target like in depression. So, but there's nothing in England so far about TMS, as far as I know.
Thank you, Elena. I think there'll be a few, Bruce.
Other people may want to say something. I mean, I'm just going to kind of say a little bit like common things are common. So very often we see people who have struggled with treatment, and in fact my colleague in the audience, Dr. Krebs, wrote a nice paper where we'd seen people who had come under our service in the kind of nationally commissioned pathway for people who were seemingly treatment resistant, and actually really revisiting and applying CBT in a very expert way, or reappraising the whole scenario. I just want to kind of say really that common things are common. So whilst the question is about, well, what happens when CBT and meds have failed, the first thing I want to do, if I'm honest about that clinically and commonly, is to revisit CBT in particular and medication. And just one other kind of related thing to say, just so that people are aware, we are obviously guided in the work that we do by NICE, which kind of has synthesized good quality research and clinical practice so that we can deliver high quality treatments. And it's quite exciting actually that NICE have decided, given that there are new discoveries and new types of research, that they will do a reappraisal of all of the evidence, because there are one or two bits and pieces coming out, new approaches to treatment, new medications that are showing slightly different promise. But I want to go back to the point for me when the commonest thing that we do clinically when treatment has failed is revisit the common treatments.
Thank you.
and I definitely endorse that, because certainly if you really look at what is good quality CBT, it may have been good quality, but it may not be at the right time in terms of the person's life. There may have been other stuff going on. There may not have been sufficient homework, the practice that they've done. It may not be intensive enough. There may be other modules to add, particularly things like looking at some of the early aversive experiences and imagery, and Paul and I have published a case series on that, using things like imagery scripting. So there's always more, I think, that can be done.
Thank you. And then the final question under treatment is, what specific examples work well for your patients when they are struggling with the sheer volume and amount of obsessions? Some tried and tested techniques that people can leave the room with. Who would like to take that one? Even if it's a repeat of earlier today. Okay.
Yeah, I just think it's the wrong question.
Okay.
I mean, it's there's not like a kit bag of techniques that you can use. So that's why everybody's hesitating, I think.
Yep.
Because again, the bottom line is it's about helping people. You know, say, I mean, I was talking to someone earlier about, say, religious obsessions, and it's like taking a major shift to introduce the possibility that your problem is not blaspheming against God, but being a religious person who's terrified of blaspheming against God. And it doesn't matter how many different types of blasphemy or how many terrifying anti-God images you've got. In a sense, it's that fundamental shift that then will allow you to then, walk into church, muttering things which I shouldn't mutter into this microphone because of the video, and so on. And that's what matters. So, and it's cutting to the heart of it rather than dealing with it piecemeal. And if you try and deal with it piecemeal, it's whack-a-mole, as far as I'm concerned. You hit that, up it comes somewhere else.
But it's interesting that if the question is there, that's what people are struggling with, and they have to understand the entirety of OCD. Thank you. Right, the next is, we know that it can be quite hard to access the right qualified therapists, and that can be quite a challenge, whether that's via the private route or via NHS. So what should people be looking for when they're choosing a therapist to support their recovery, and how easy or even possible is it to self-refer? Elena, what are they looking for when someone is looking for a therapist? What makes a good therapist?
Let's see, if therapy has failed, as Bruce and David were saying, I mean, we need to revisit the expertise of the therapist. There is a lot of ineffective therapy I see going around, and also when people come to us referred from to the national service or even locally, usually, it happens often they haven't received good CBT, or they've received exposure without, really going to challenge their beliefs. And I'd say choosing a therapist with an expertise in OCD is important. There's a lot out there on the internet, and the services available nationally. It's quite hard to get referred if you need to meet the national criteria. So if you look at being funded by NHS England, but there's always a scope to be referred by the GP and looking for local funding to get referred into one of the national services.
Thank you.
I was going to say, not only the obvious things like experience and training or accreditation under the BABCP, but, are they passionate? Are they about beating OCD? Are they really take a passionate interest in that, rather than necessarily being a job of... I mean, I wouldn't dream of trying to treat someone with CBT with schizophrenia. I wouldn't know what to do. I just don't do it.
I would just add, Paul, I was at your talk and I was really impressed by, you were really honest about the relationships that people can have with therapists. You must start with, so I'm pleased that you said, look at organisations such as the BABCP. Also, OCD Action can help sometimes direct and help people think about where to get good therapy. But if you're starting your journey with a therapist, it's really important that you build that rapport. Ask them questions at the beginning. Ask them questions. How many people have you treated with OCD? What's your success rate like? What approach do you take? Go armed, ask questions. You know, particularly, well, whoever you're seeing, NHS or private, you don't want to invest your time and money and life in something that's not going to be right. So you can't pretend that everyone's going to be able to do a good job, so go armed with the right questions.
Thank you. Paul?
Add to that, Bruce, I agree with you, but if you ask the question, the person says, I haven't treated anybody and I'm a trainee, that's fine, provided the person's owning up to it, because a trainee is less likely to be up themselves, they're more likely to be up to date, and they're more likely to actually essentially work in partnership with you. And if you've got that, and then also the person is prepared to listen to your story and seems to have the kind of right values, what you're talking about as passion, and so that's fine. So I know you didn't mean it that way. I just wanted to correct the idea. Trainees are brilliant, actually, very often, but then you want to make sure they've got supervision. So they've got Bruce sitting in the back and sort of going through with them later and so on.
Thank you. We had a fair amount of questions about being a parent whose child is unwell. And there was a mixture of either the offspring being a child or the offspring being an adult, actually, and you're parenting an adult. The parent is often the first port of call for support. How does a parent support their child? And the scenarios that we had were whether to give or not give reassurance and being mindful of the impact and the consequence of that, whether to section, how to provide treatment when they don't want it, when they believe they're OCD. So I'm obviously looking at you both too.
You are. So I might deal with the reassurance seeking one. And I think it's picking up on what Paul said earlier, that we wouldn't be advocating, sort of, unless you're in treatment, to just say don't reassure. I think it has to be really carefully guided in CBT and thinking about kind of the role reassurance plays in kind of maintaining the OCD, and then collaboratively with the family and with the young person or the adult, thinking together about how to address that, and just coming up with a plan together. And I think in the young person service, we do really involve family members, anybody who's getting pulled into the OCD or not, just to help them understand what's going on for that young person. It's really important for them to be involved in the treatment to help to best support them, because we know it impacts on young people, but the families equally. But I might hand over for the sectioning and the other questions.
I missed the little bit about sectioning. Can you just bring me back in tune there? It was just, should they be sectioned, I think.
Is it ever worth, I'll read you the full part of the question.
Right.
Is it ever worth pressing for the sufferer to be sectioned against their will?
I think there are very, very rare circumstances where a person should be detained under the Mental Health Act, or sectioned, as that is sometimes called, where their liberty is taken away and they're brought into hospital. It should only ever be in the most extreme mental states generally, and I would say particularly for OCD, for a lot of reasons. I think people are always very, very keen to treat OCD in a much more natural, home-based environment. It is extremely unusual to be treated under section where you have OCD, but there are very rare circumstances where that might need to be the case for a person's general safety or the safety of others. So it's not that it can't happen. We don't necessarily have time to go into it, but the bedrock of treatment for OCD is psychological therapy, and it's a psychological therapy where you are gaining your own mastery of your treatment. And to do that with somebody who perhaps has had their liberty taken away and being forced into situations can make it very, very tricky. So very often people are sectioned when it happens, in those extremely rare circumstances, for things that aren't necessarily directly related to OCD.
Thank you. So the next one is looking at medication, and I really do appreciate, Parental, it's hard to discuss medication for specific cases, but quite a few questions came through, specifically talking about the side effects of taking and coming off medication, in particular clomipramine and sertraline. I appreciate it's quite a general question, but I'm conscious I didn't want to ignore the people that have asked about medication. So if you could provide some insight. David?
So what's the specific?
Is how you deal with the side effects of taking or coming off medication.
Well, there are whole legions of side effects, so there's about 20 or 30 potential ones, and there are some remedies for quite a few of them in terms of whether it's dry mouth or whatever. So there are possible ways of dealing with each of those side effects. It's more of a problem, as you say, potentially perhaps coming off, and the most important thing is usually coming off slowly and trying to... It's interesting, you often get more problems, I think, coming off these drugs with depression in terms of discontinuation, withdrawal type symptoms. You don't tend to get it so much, I think, in OCD when you're coming off them, but the most important thing is doing it slowly. But the problem being is that there is often, if the medication alone has been helping you, there's a high rate of relapse when you stop taking them. And so usually within 2 to 3 months, that might be the sign of perhaps some of the OCD symptoms coming back. So that's why it's really important to combine it with any CBT as well.
Thank you.
I would just add, it's actually quite a big topic to think about, but it's, I guess, something that David and I do a fair amount in our clinical practice. Children and young people have a different sort of range of side effects that they might experience and different vulnerabilities to those. And the other thing is a good number of people that we see in our clinical services have autism spectrum conditions as well as OCD. It's about a third of the patients who come through our particular clinic have that combination. And people with autism spectrum are particularly vulnerable to side effects and need slightly different approaches to induction and removal of medications. I would also add that young people, and I guess some adults too, can be, particularly when people are getting better very often, and they're getting their lives back and they're perhaps going out and going away for weekends or staying out late and so forth. And so there are a number of things that guide your choice sometimes in medications. There are certain medications that are better if you are going to go away for your long weekend in Ibiza and forget your meds for the whole weekend. So there's lots and lots of factors that need to be part of a decent, transparent conversation.
But ecstasy in Ibiza is not a good idea.
I didn't say that, David.
So a follow-up, and I must admit I'm not sure who to direct this question to, is are there any advantages of taking supplements alongside SSRIs? This person has heard that NAC, vitamin D, fish oil and multivitamins may have some positive effect. Do we have any evidence of that?
NAC is N-acetylcysteine, and I believe there is one small trial or two where adding it to SSRIs may have had some extra benefit, but these are very small, early studies. I can't think of any other supplements that have been shown to be helpful.
No, and several other trials, and people try and read over from research in depression, and I would add largely adult trials, so there's less known for children and young people, which are very variable. So really there isn't a lot to support that. There's been a fair amount of interest in depression and vitamin D, and Lynn, if she was here, would remind us that she published a study showing that where people have had quite chronic and severe OCD, up to 80% of them have depressed mood. So we often get asked, or people want to think about vitamin D, but there isn't good research behind it. And the truth is a balanced diet very typically gives you enough vitamin D. Perhaps we need a wee bit more in the winter. 20 micrograms in the winter is what the government recommend in this country for all Caucasians, in fact. Or a trip to Ibiza for the weekend. That's much nicer.
A trip to Ibiza.
Tough choice.
So we had a fair amount of questions about how to navigate the system and try to access therapy. And again, I know some of this has been covered earlier and some this afternoon, but the reasons that people gave were that funding nationally for NICE compliant care can be poor. There's a limited personal amount of funding for private therapy. There may be situations where local treatment has been exhausted or it's not available, or perhaps they don't meet the criteria for NHS England funding, or what happens when someone relapses. And I appreciate there's lots of elements attached to that question, but I think the main thing that came through all the inquiries is there a limit on how much CBT can be provided on the NHS? And if that's the case, how can someone navigate the system to get the treatment that they need?
No, there isn't a limit on how much. Different commissioners will impose a whole host of different rules. Nationally, all of us work in specialist services and we'll all see this, but there isn't some sort of central textbook of commissioning that says after X number of therapy sessions you can't have more. I'm going to be stealing an analogy that Paul used earlier about commissioners wouldn't say you've only had 5, 10 or 15 sessions of chemotherapy and your tumour hasn't shrunk enough, so fight. That would be my advice, and I would say that OCD Action can be tremendously positive with their advocacy service. Sometimes people phone us up in our clinics and we sometimes try and help a little bit, but OCD Action's advocacy service can be really, really powerful and helpful, certainly in the United Kingdom, in helping people navigate. But I'm almost ashamed to say you sometimes have quite a fight on your hands.
David, I have a specific question that was asked of you, so if I may, it says, thank you, Professor Veal, for being such an advocate for patient choice. However, is it true that the only OCD-specific service that accepts patients referred through patient choice is CADAT? And if so, why and how do members of the panel plan to address that?
I don't think it is true, because I'm sure Paul's clinic will accept patients from the patient choice.
Our clinic started 2 weeks ago, and I've asked the Trust if it could be open to patient choice. We've not been informed yet, but I certainly would like it to be. Just briefly, Mary, can I go back to the previous question? Because there are very good data. I talked previously about IAPT. There are very good data from IAPT which show that more treatment is better, that those services which limit the amount of treatment that people get for OCD and for other problems essentially do worse. And so overall, it's very clear that actually there's really good evidence that a short wait and a reasonable amount of therapy approaching what NICE recommends are much better. So yeah, sorry, just thought I'd add that.
No, but the principle still is, after the coalition government introduced patient choice for mental health, it hasn't been implemented very well. And I think part of the, in theory, you can be anywhere in the country and asked to go to a different place in the country, where even an IAPT service in terms of where you want to be treated. But I'm afraid even the providers aren't actually very knowledgeable about this in terms of the foundation trusts and so on. And I am worried because there is some movement now by NHS England perhaps to try and restrict choice in some way on the basis of cost effectiveness or good value and so on. So it may be that OCD Action may have to activate Houses of Parliament and House of Lords to find out exactly what is going on down there, but it's a good principle, and it's very difficult therefore to get good specialist services in OCD unless you have that choice, if it's always going to be restricted to your local service.
Thank you. So we've had some questions submitted about the origin of OCD and whether it is a mental illness in its own right, learnt behaviour and or a result of trauma, and also how relevant past experiences are when working with OCD. Panel, what are your thoughts? So it's very open-ended. Who would like to take that first? Yeah. Oh. Paul, then Bruce.
We don't know what causes OCD. There's absolutely no evidence to suggest it's caused by anything in particular. It's probably multifactorial. What was the last bit of the question? So it was working with
past experiences.
Well, I mean, the most obvious example of this is the recent work on mental contamination, where looking at people's associations, where it isn't PTSD, but it has some resemblance to PTSD. So that's clearly important. And again, when people have essentially some sort of traumatic type roots, then it's sometimes helpful to do that. But you would always start with working on the maintenance and what you can do with that. And then if there's residual issues, particularly around beliefs, I gave an example this afternoon of a little girl who thought she'd killed her grandmother. So for those of you then it can be really helpful to deal with that, and it's on a case-by-case basis. But it is not essential to deal with the origins for most people, and typically working maintenance is enough. mental contamination, I think, is now becoming fairly clearly an exception.
Thank you. And Bruce, did you want to add to that? Or?
No, well, yeah, okay, I do. People often ask us this, and the truth is the treatment doesn't depend on where it comes from, but the answer is, the best that we know is that in some senses OCD does run in families. Genetics are a contribution to, it isn't the same thing, but genetics are a contribution, but we don't know what that means. Most mental health difficulties where our genes contribute to the causation of having OCD is that all the research shows that there isn't necessarily a broken gene that needs to be found. There are genes that are perhaps involved in creating the backdrop to OCD, and it's the particular fingerprint and makeup that contributes. Now, what is known from that is that that is only a partial contribution, and that's only known from large studies where you look at lots and lots of people. So genes can have an influence. And then, of course, environmental factors have been looked at a lot. There was a really good study in Sweden not so long ago looking really carefully to see if there are any particular types of environmental experiences that people have definitely had that causes OCD, makes OCD happen. And people have really, really struggled to get to the bottom of that. So I just want to go back to, it's kind of important that therapy should be focused on getting better, and whilst it's important to understand some of those key factors if they're contributing to things, it shouldn't hold back treatment.
Can I just say, the genetic data are extremely ambiguous. I think it's potentially harmful to be talking about this. And I would remind you that over the last week, we've seen one of the, in biological psychiatry's holy cows, been essentially looking like it's about to be debunked. The therapy, the serotonin transporter gene, a long-running story, a massive amount of data, it now looks like it is completely wrong. I think it's really important that we are absolutely clear that we do not know. The fact that it runs in families does not mean it's genetic. There are people in this room who've chosen not to have children because they were concerned about this. There'll be people in this room who might still be considering this. There is no evidence for a genetic component any more than there's evidence for a genetic component for your ability to read music, to dance, to play chess, and so on. And I think we have to be really careful about how we communicate this. The science is so weak as to be essentially almost non-existent in this area. And I hope it gets better, but right now I think we have to be careful about being overly confident about what we understand about causes. We know nothing about causes.
I hope I didn't convey that we were confident, but there are multiple types of research. I appreciate there is ongoing debate, and it's important that we better understand that.
Thank you, and I think it sounds like that could be a whole session in itself, and I'm conscious that we have about 7 or 8 minutes, and I'm really keen that we spend the last part of this section on supporting the audience to know how to maintain recovery, and that was something that came through quite a lot with the questions. So we had different categories. If we're thinking about how to maintain recovery, it could be planning to attend university. How do we support someone who's doing that and they're concerned about any triggers? Do you actually continue to carry out exposure once you've recovered? Why does OCD jump from one fear to another when you feel you've got better and then it moves again? So I'd love for each member of the panel actually just to spend a minute and a half, if I've got my maths right, on how to maintain your recovery. So I'll start with you, Rita. Thank you.
So I think we, in our clinic, we follow up for a year following treatment because we feel that period of time is really important, probably beyond that, just to keep people topped up with what they've learnt in treatment and doing more exposure tasks and reminding them of the tools, because it's quite a vulnerable time when you've had a course of treatment, you've been seeing somebody regularly, and then it feels like you have nothing. So I think in answer to that question, I think using the tools that you've learnt in treatment, but hopefully the services that you have access will also offer follow-up and support, because it's really important to have that ongoing support. And I think transition times are really risky, and knowing sort of what might be the potential kind of indicators of relapse. So people going to university, we hear lots of young people that kind of move into university. That's a real stressful time, and sort of being aware of that and putting support and provisions in place. So I know OCD Action have got some leaflets around that and support to kind of be given to universities so they can help support people that go through that transition. So I think follow up and just keep using what you've learned in CBT is really important.
Thank you. Bruce, how do we maintain our recovery?
Well, I would just add to that. I think that's the important point to magnify. During the course of psychological therapy, you become your own expert, you have the techniques, and hopefully good therapy will get you ready for the finishing when you're feeling much, much better and ready for the future. We also have the privilege of working ordinarily in children and young people services. We work with people's families, and we're actively encouraged to include parents in treatment. So parents and next of kin across the age spectrum are a really good support to kind of spot signs and symptoms, and also have learnt some of the techniques to really be part of a wider support network to keep someone on task and thinking about the future. There are also things to think about medication in terms of maintenance. Medication can have a role in maintenance, and also we have to have very careful conversations and thoughtful conversations with people about when they may choose to discontinue their medication.
Thank you. Elena.
I'd say the same during therapy to work carefully through a clear relapse management plan. So whilst we're still doing therapy, and during therapy to push towards an anti-OCD position. So not aim to be normal, but take more risks that the so-called normal people would take, because it's normal that time of stress, then the OCD will come back, and it's important that we tested out a riskier situation. And then, to be aware of relapse signs, and, take people on board in terms of family support network, and, also keep a healthy lifestyle. And if there's a decision of coming off medication, I'd say to do it under medical supervision and very, very slowly.
Thank you. David.
Well, hopefully by the time you've been discharged, you can become your own therapist, that you've got your own relapse plan, that you can identify some of the triggers of things that might come up, and be ready to be able to implement the things that have been helpful in the past. In my experience, I think that if you, say, have had contamination OCD and it's been focused on one thing, then it may jump to something different in terms of in the same theme, in the same way if you've got intrusive sexual thoughts or something, it may jump from one type of thought to another one. So that's the key thing, I think, to be warned, to be ready that these things may change, they may transform into something different.
Thank you. And Paul?
Well, what they said, plus the importance, I think, of developing, the things which I've called elsewhere dreams, actually reclaiming your life, building a new identity, which does not have OCD, and the fears that you have at the core of that. And actually, my impression is there are certainly some people who overcome OCD and then become something better than what they'd been had it not happened. And I think there are some of those people in this room, actually. So I think it's a question of what kind of identity you would choose for yourself, and then seeking that.
Thank you. So, panel, thank you so much for all your expertise and insights. And just to try to sum up the main messages from this afternoon, treatment will sometimes feel tough, but the moment will pass, and you will start to benefit from your hard work. Please do contact OCD Action. They have great support services and advocacy services. More treatment is better. There is no limit on the NHS for CBT, so please fight for it. Be aware of your possible triggers. Implement the techniques that work, that you've had during your therapy, and seek out your wider support network. Be aware of medication, as in whether you're maintaining what you're taking or you're coming off it, but do it under medical supervision. Sometimes live in the anti-OCD world. That's important to maintain your recovery, but there is hope. You can recover from OCD, and please reclaim your life for that to happen. So panel, thank you very much.